Hi, I'm Dr. Martin Rutherford.
I'm Dr. Randall Gates.
And I'm a board certified functional medicine practitioner. I'm a chiropractor for 36 years.
36 years.
Me on that
yes, exactly.
Since 1979. And Dr. Gates is a
board certified chiropractic neurologist, as well as being a chiropractor.
And if you can't tell, we've got about 200 hours online, and we're getting tired of saying this on everyone. But we're going to say it on everyone.
We always say
just so people know, what's going on here. And for those of you who watch this, we have a chronic pain practice. It sort of developed out of the marriage of both of these disciplines. Dr. Gates's discipline is largely focused on the brain and the nervous system and pretty much everything that affects it, nutritionally, biochemically, and so on and so forth, stress-wise. And functional medicine is now growing, and people are out there starting to at least think they know what it is. And it's a very organized discipline to address the abnormalities that are taking place in people's physiology that are causing their particular symptoms. So we're more interested in what's going on and what needs to be corrected than the name of what you come in here with, which leads us to today's topic, which is Lyme disease. I must tell you, we probably treat just about any type of chronic pain issue that there is out there short of cancer.
Right.
Okay. And we don't do cancer, period. All right. And there's a lot of reasons for that, but we won't get into those. So, so there's a lot of controversial disease out there. Last week we did Epstein-Barr.
Yep.
And that was done on request. And to our biggest fan, whoever that is, and back in Southern California, we're going to be honoring your request next week and doing anxiety. And
right. It's Becky. I won't say
Becky. I'm sorry. Becky, he didn't tell me.
I've talked to you, Becky, online.
Oh, he didn't tell me that either. Okay. So anyway, but this subject this week, we've kind of flown under the radar on this one. It's interesting. We get certain folks that come in here and it's very possible or probable that we could help them with the types of things that we do here with our paradigm for chronic pain. But sometimes the person comes in with hardwired, that's your term, hardwired ideas that almost simply just can't be changed. And when those ideas are wrong, and if we sound like we think we're experts on this, we think we're experts on this based on what we've seen.
But we can't say the term expert.
Oh, we can't say that. I'm sorry. We're in Nevada. I can't say we're not experts. Okay. We've just seen a whole lot of these things.
And it's like all we do.
And it's all we do. And this is what we see. And this is how this is how we share with you on what we've seen and what our results are. And there are folks that come in and they have certain paradigms about parasites or candida or electromagnetic forces or whatever. And all of them seem to have some validity for somebody, but not everybody. Not every person that comes in here needs to be checked for mercury poisoning or whatever. I think those of you who are watching probably know what I'm talking about, because that's kind of seems to be the audience that we have. We seem to have a very intelligent audience based on what we get after these talks, as far as emails and so on and so forth, particularly in the alternative field. So I'm saying all that to say this: the Lyme group seems to be like, now don't take this personally, okay, but like the worst. And when I say the worst, I mean the Lyme group seems to come in with the most fixated, incorrect data that it is sometimes difficult to break through. And when patients come in here, we do a mind-numbingly thorough evaluation to determine whether that patient could respond to what we do or not. It's rare that we're off. And one of the things that we have to evaluate is that patient going to be able to let go of what they are? Oh no, it's my babesia, and I got to do this, and it's like, man, that's half of that's killing you. Just the stress over it. And we have to, and we have to get that person to let go of this. The Lyme patients, I think, because of the isolation of them out as a specific patient population, and then there's only certain doctors
that treat them, and the mainstream medical community doesn't know what to do with them or acknowledge them.
So let's just say that we treat Lyme, and this is the first time we've ever done anything on Lyme. We have never did a talk on Lyme. We have flown under the radar on this, but it's time. It's just time to say something about this, because our patients are doing well. And I mean, we're right now, it's been here for 3 weeks, maybe 3. You know who I'm talking about?
I can't remember who you're talking about. We have so many.
The lady who travels around the world with her partner, and they research. She's a journalist. She's an investigative.
Oh, yes.
She's an investigative journalist in the alternative field, which made it even worse because she really was certain that she was certain on what Lyme was. She's been to several Lyme clinics.
I know who you're talking about.
And still doing worse, doing the classic stuff. So anyway, but she's been here about 3-4 weeks now. She's doing like ginormously better. She's ecstatic and all this type of stuff. I'm not saying that's our classic, typical, tremendous result, but we get good results with this, like consistently. So we're going to share with you our take on Lyme. We're going to acknowledge what we feel has a gentleman who's written one of the better Lyme books out there. And this is a rather lengthy intro, and we have a lot to cover. So I'm gonna wrap this intro up. But so for those of you who have Lyme, you're gonna hear some different stuff here. But we are gonna cover Lyme from beginning to end, where it started, what happened, why you have the data that you're having, why you keep going through all these treatments and not getting better. And I know there are some people going through treatments that get better, but there's a reason for that. Even Dr. Horowitz would acknowledge that. So that's what we're gonna do. And so I guess we should get going because we do have a lot to cover if we're going to give you a real full picture of what we had to learn and what we had to know, what we had to understand about the patient before they even walked in the door, and then ultimately, what treatments, what the real issue seems to be, and what treatments seem to be helpful. Okay, so Lyme disease in America and Europe. Where did this start? I'm from the East Coast, so I have a little bit of a background on this.
Absolutely.
Trudging around through the forests of Pennsylvania and New Jersey, but go ahead.
And so it was first labeled as Banworth syndrome in Europe back in the 1800s. And then physicians around the time of 1909 started noticing these rashes on some of their patients that was associated with arthritis. The rash is called the erythema, at that time chronicum migrans. Now it's the erythema migrans rash that is collectively known. That's the bullseye rash that many of you have heard about. And it wasn't really until 1975 when a group of mothers were coming to their pediatricians and family physicians with kids who had these flu-like symptoms and arthritis, and it was a very peculiar presentation because you wouldn't suspect that many kids in one area to have like juvenile rheumatoid arthritis. And they started looking further into this, and this was in Lyme County, Connecticut, and hence the phenomenon of Lyme started in America. Some people say that it was here before that because people were talking about the rash. Others say, did it just pop on the scene? There are a lot of controversies with even
some conspiracy
theory stuff. And we don't need to get into that. You just need to know that there's controversy over whether it was here or not, or whether there was just this massive outbreak in 1975. Needless to say, what you need to know out there is that ticks do transmit this. I think most of you know that, but there is some misinformation regarding the ticks as well. So there's a tick on the East Coast. It's called Ixodes scapularis. That's the one that most commonly transmits the Lyme bacteria, known as Borrelia burgdorferi. And there may be other species of Borrelia within that tick that are not commonly acknowledged by the infectious disease community here in America. Then there is the tick on the West Coast called Ixodes pacificus, and that can also transmit Borrelia burgdorferi. However, most researchers will say that it doesn't transmit it as commonly. There are some reasons for that. There's a gentleman from UC Berkeley back around 1992 who discovered that the pacificus tick, or just the deer tick over here on the West Coast, likes to jump onto a lizard. And it turns out that the lizard possibly secretes an antimicrobial agent back into the tick. And so the tick will be anesthetized, or basically it will have the Borrelia bacteria killed within it. Does that make sense? Mm-hmm. Yeah. And so it's really, really interesting. So that's possibly why Lyme disease is not as prevalent on the West Coast as it is on the East Coast. However, there are travesties here because just so you know, we've talked to some patients who have said, I talked to my general practitioner about having Lyme disease, and he said it doesn't exist on the West Coast. Doctors are responsible for a lot of information. Basically, they know the information they were taught in medical school or in residency. And that is what is disseminated by the infectious disease community, that lots of times basically Lyme doesn't exist on the West Coast. However, the data is that it does exist on the West Coast. And
we see it.
And we do see it. And so you have to be aware of that. It's not as prevalent as the East Coast, or New England or Wisconsin or Minnesota, but it is here.
Yeah, for those who's never seen us before, we're in Reno, Nevada, so we are majorly West Coast here.
Yeah, exactly. So that's really the history of Lyme from that perspective. I think that
okay. Yeah, and so Lyme disease is the treatments out there for Lyme disease are interesting. Interesting. Now, and those of you who watch this, every time we do like some sort of a snippet or we do one of these presentations, I say, I have that. I don't have this. I don't have it. So it's been interesting for me to have to sit on the other side of the desk and listen to these histories of something that I've never had. Most people, I can understand what they're going through, but this whole situation of Lyme, and we're going to cover this a little bit, is like pretty much Lyme can cause like pretty much any symptom known to man, according to the Lyme community.
Exactly.
Okay. Do we want to go with that, or do we want to go with like the guidelines for treatment next, or
let's go acute Lyme.
I want to make sure we cover everything here. Okay, let's go acute Lyme and guidelines for treatment for the acute Lyme. And this is very important: acute versus chronic, and this is important.
Mm-hmm. So there are times of the year when you're more likely to get Lyme disease. Ticks have a maturation stage just like any other animal. And so they have a baby stage where they're called nymphs. And the little nymph ticks are more likely to give you Lyme disease than an adult tick. And those little nymphs are running around more in the springtime. And so if you are an avid spring hiker, that is the time where you have the greatest probability of contracting Borrelia. Now, if you are out and you see that you have a tick on you and you live in New England and you take the tick off, typically the standard of care is for you to go on doxycycline, which is an antibiotic for about 28 days. And there's a certain dose that we don't need to do. And that doesn't matter. So that is the standard of care there. If you develop the bullseye rash,
it is important to do it ASAP.
ASAP, absolutely.
Like the second you see it, you get it out, don't even wait.
Yeah. Don't wait for the fever or flu-like symptoms
to set in.
Go. Right. 100%. Couldn't agree more. And if you develop the rash, same thing. The doctors won't even need to run a blood test. They'll typically treat you. Some doctors do run the blood test, and it's called an ELISA test. And the ELISA test does have some validity within the first 30 days. Now, there's discrepancy about that. Some people say it's only 65% sensitive, and it's not a good screening technique. And that's why if you see the tick on you, or if you have the rash, you need to get treated. Although some doctors like to run the ELISA test. And if that's negative, some doctors will run the Western blot test, which is a different type of test that's more for chronic issues with Lyme. And we'll get into the whole chronic Lyme debate. But they may give you antibiotics in that scenario too. Really, as Dr. Rutherford said, if you think you got bit by a tick or you saw a tick, you need to get into your doctor ASAP and get this treated right away. One of the things that struck me about Lyme disease when I was learning medical bacteriology is that if you don't get it in the first 30 days, you're probably going to have it for a lifetime.
Right. That was the key.
Yeah.
That's why I said that. Don't even wait. You don't have time to wait. Because if you get into, you're going to have it for a lifetime. Now you're getting into the patients that walk into our office. And let me tell you, the gauntlet is long. It is expensive. It is crazy, in my opinion. That's my opinion.
No, absolutely. Absolutely. And
I don't want to say anything that's not specific enough. Dr. Gates has always protected me from saying something's going to get me in trouble. and by proxy, get him in trouble.
We're very cautious. There you go. Yeah. So yeah, you need to get treated right away, because if you don't, then you could have this potentially for life. And within the standard infectious disease community in America, let's say you got exposed to Lyme and you didn't get it treated. They may give you antibiotics for a short length of time, but really their standards are that you shouldn't be on antibiotics even if you have this chronic Lyme picture. Lyme disease or Borrelia is very similar to syphilis in terms of how the bacteria looks under a microscope, in terms of how it acts. As Dr. Rutherford said, really Lyme disease can present with many different symptoms. Syphilis used to be called the great imitator of disease because it could manifest like multiple sclerosis or spinal cord issues or arthritis or a number of different things. And really Lyme is very similar. I think now they call it the disease with 1,000 faces or something like that. I can't remember specifically, but it's something of that nature. And so again, you got to get treated right away. That's really the point on acute Lyme disease.
Yeah, and the prevalence of Lyme is pretty extensive.
So
and this is why we kind of did this one after. For those of you who didn't see us last week, we did Epstein-Barr virus. It's like everybody's got Epstein-Barr virus in their system. Not everybody, okay,
right.
but close.
Mm-hmm.
But a pretty significant. So a lot of times you'll get tired. You'll go to the doctor. Maybe your doctor has been schooled that Epstein-Barr virus could cause chronic fatigue. They check it. You got Epstein-Barr virus, and next thing you know, they're all over it, and you're not getting better. In fact, maybe you're getting worse, and then you can watch that on. This is kind of a little similar to that.
Very similar. Very similar.
Kind of
we'll get into those mechanisms too.
But the prevalence of it being present is large. I mean, who hasn't been bit by a tick?
Right. Exactly. If you go outdoors.
I mean, I don't have Lyme, but I have been bitten by ticks. You know, growing up in New Jersey, I can remember, my mother freaking out and digging that tick out of me and stuff.
Yeah. And up until 2012, I think the CDC was saying that there were 30,000 cases of Lyme disease a year. Basically, those were reported cases where a doctor says, I'm going to call the CDC and say, hey, I have a case of Lyme. Now the CDC has come out and said, we think there's probably 300,000 cases of newly diagnosed Lyme disease
That's
every year.
1 out of every 10 people in the country.
1 out of 100.
Oh, I'm sorry, 1 out of 100.
But a lot of physicians, including, we're going to talk about this fantastic review article from the International Journal of Family Physicians, where they say, it's probably way more common than even 300,000 newly diagnosed cases in this country a year. And these are newly diagnosed cases. So like what you're saying, the global picture of how many people have been exposed to Lyme may be pretty large.
Yeah.
And so that is a revelation in and of itself, because lots of times Lyme sufferers, or the chronic Lyme patient, they feel ostracized because no one acknowledges that Lyme exists on the West Coast, or that chronic Lyme even can cause problems, or that it's an actual entity.
How common is it for your, what word do I want to use, for your MD, who is classically trained, being polite here, to diagnose Lyme? Are there a lot of MDs who won't diagnose Lyme?
There are a lot, exactly, because the testing sucks, and nobody can agree on the testing. This is really the crux of the issue.
It's inconsistent and it's unreliable.
I mean, if we have a good,
that's the testing.
We have a test for, even though we argue about thyroid and how to test for thyroid, there are guidelines out there that say the TSH over 3.7 is an issue and that needs to be diagnosed. With Lyme disease, it is a confusing matter as there is in medicine, because, as I mentioned, the ELISA test, which everybody loves to use, is only really accurate within the first 30 days. Then you're supposed to do a Western blot test. The CDC, when they jumped from 30,000 to 300,000, that happened because they were using Western blot tests to look at the surveillance of Lyme disease. However, those Western blot tests are not supposed to be used in clinical diagnosis. It's just supposed to be for surveillance, according to the CDC. However, then there are two different camps of Lyme disease paradigms, and we're going to get into that. But one camp says, well, you need to do the Western blot on everybody because it's more sensitive and specific for chronic Lyme disease. But then it won't show everything either. So it's going to miss another 20% of the cases. And so hence we have a tremendous amount of confusion. And then in this wonderful review article from this family physician journal, they said there's actually data coming out that maybe Lyme disease is actually an autoimmune issue. And so
this is where we're going.
Because we're looking at the bacteria is there. You take the antibiotics, you kill the bacteria, and there are a lot of studies showing that even after that antibiotic administration, people still have a lot of symptoms, but they can't always find the bacteria. And is it because there's an autoimmune mechanism that we just don't have the laboratory capability in this country yet to diagnose? Other people are saying the Lyme bacteria can take on many different forms. It can encapsulate itself. What's the the biofilm people. So then they're saying that there's a biofilm issue so that the antibiotics didn't get to the Lyme. I mean, it gets ridiculous. Ridiculously complex.
Hope we didn't insult the biofilm.
But it gets ridiculously complex.
That's just another
I'm
one
not
of those.
knocking it. I'm just saying that, you know, everybody is on to all these little disparate pieces and we just don't have all the information.
Right. And we're going to.
Yeah.
And but again, we're coming from a perspective of clinical observation. For example, Doug Gates has been here for about, what, 5 years?
Mm-hmm.
I guess
years.
prior to Doug Gates getting here, I treated this one couple who came back after you were here. And I think there were a couple, I can't say their names. So they came down from either it was Idaho or Oregon. The husband was an African-American.
Oh, I know who you're talking about. Yes.
And
yes.
So, and she came in and we treated her for, I don't know, it was chronic fatigue or fibromyalgia or something. And she got substantially better. Well, we didn't know she had Lyme. It was like, oh, you have Lyme? She's going like, how come my Lyme is getting better? And that, you know, when things start happening like that in the course of clinical treatment, then the antennas start going up and you start understanding that this is massively inconsistent with what these people were told. So they were either misdiagnosed, but they were not misdiagnosed. Well, I mean, but they had testing to show that they had Lyme. But as we're saying here, the tests are inconsistent. And all of a sudden they started getting better. So that opens up the whole new vision for us of like, whoa, maybe we better start looking at some of these Lyme cases and see how these fit in. What can we learn from that? And what we're sharing with you is what we've learned from that. So you wanted to like,
yeah, let's go into the two different camps of Lyme theory. Okay. So infectious disease specialists, they're very smart people. They work with, you know, dangerous skin eating conditions and things like that. And so they're the ones responsible in medicine for being the experts on Lyme disease. Okay. And so it is they who have set forth these guidelines such that they have said, these are the antibiotics you use in the first 30 days. These are the antibiotics you use if the person has a rash. These are the antibiotics you use if somebody presents with meningitis, which is inflammation of the outer sheath of the brain and the spinal cord. Those are the things you want to do. And then they also say that after 30 days, basically, there is no definitive chronic Lyme syndrome. There are many names for it. It's post-Lyme syndrome, chronic Lyme, post-syndrome, I mean, all these different eponyms. But that is what they have established. They say that there may be this chronic Lyme phenomena, but we don't have the laboratory capability to quantify it yet. So that's what they say. Then there is the International Lyme and Associated Disease Society. And they present all these statistics saying how inaccurate the ELISA test is, how you have to do Western blots on all these patients who present with things like chronic fatigue and fibromyalgia, rheumatoid arthritis. They also will say that the Western blot may not catch all the cases. So therefore, if a person has ever even seen a tick, they probably have Lyme disease. I'm being a little facetious, but not too facetious. And I'm really trying not to knock it, but they tend to be the group that says Lyme disease is way, 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 way more prevalent. And not all these doctors, but some of these doctors really go into the antibiotic regimens and that, or chelating regimens, and that creates a lot of controversy in medicine.
But this goes to the heart of what we educate our patients on, whether we're doing a talk or whatever, that what you're describing is the acute pain model,
right?
And the acute pain tools.
True.
So they're not going to acknowledge a condition that they have no tools for.
Right.
Is essentially it. Your medical doctor is in a model that it's like you have acute problem, cut it off. And again, we work with medical doctors. We're not anti-medicine. They would agree with exactly what I'm saying. Use an antibiotic, use a drug, speed it up, slow it down, kill it, whatever it is. But that's an acute pain model. Once you have crossed over into the chronic world, there are certain consistencies that we're going to talk about before this is over that, again, to add on to, the testing for almost all chronic pain is poor. It's inconsistent, or it doesn't even exist. And so now you have an acute pain model that works on the test. You have all these symptoms, but we just tested you for Lyme. It's negative, so you don't have it. And we see this all the time. Or you have it, and we're going to treat this chronic problem with acute pain methods. We're going to give you antibiotics from now until doomsday.
Right.
Okay. And that's the trap that you are in.
Yeah. In our opinion, some of these physicians, not all, we're going to cite one of these physicians who we really admire, but some of these physicians get a little overzealous, and it's almost like everybody out there has Lyme disease as the cause of all of their symptoms. And we don't feel that.
And others think nobody's got it.
Yeah. Accurate. Yeah. There's probably a middle ground here.
Yeah. There is.
There is. Yeah. So then there's a general practitioner's viewpoint on Lyme. And out of all the reading on Lyme and everything we've done with Lyme, I thought this was the best article. I attached it. There's a free link to where you can access the entire article if you can bear through some of the medical ease, but it is wonderful because in this article, they talk about how GPs are really the ones most commonly interfacing with Lyme disease patients. And now let's talk about chronic Lyme disease patients. So the chronic Lyme patients are going to their GP saying, hey, I have all these symptoms. I'm not feeling well. What do I do? And lots of times GPs they don't know what to say because they were trained in the acute pain model. And this article really presents that there is this chronic Lyme syndrome, that we don't have good lab testing for it, that yes, the bacteria may take on different forms in the body. However, is that really causing the issue, or is it more an autoimmune issue where the immune system has become overreactive to the Lyme bacteria, and that has caused a number of the symptoms? And that's really the summary of that article. But it really was a nice, I felt like middle of the road article, just because they acknowledge what they're taught by their infectious disease specialists, but they're also acknowledging what they are seeing on the front lines, and the fact that 300,000 newly diagnosed Lyme cases a year is probably even a low estimate.
It's a lot.
Yeah. And we've seen cases, this has to be iterated, that where the kid has Lyme disease and has all the symptoms of Lyme disease. The parents actually took a Lyme test, and the parents both have Lyme disease as well, but the parents have no symptoms.
Right.
So,
and we're going to talk about that.
Is there
We're not going to talk about it now. We're going to talk about that because that is a extremely important point for you to understand.
So is Lyme disease, just because all of us haven't been tested, is Lyme disease becoming like Epstein-Barr virus? That is the question.
Was what I said.
Where so many of us, so many of us have been exposed to Epstein-Barr, but most of us don't have symptoms, but some people do have symptoms for certain reasons. And until you address those reasons, the person's going to have chronic fatigue and not feel so.
So we had this conversation, and I think it was after that couple. No, because that couple came back. I treated that couple before Dr. Gates was here, and then something happened, and they came back. She did well again.
Yeah.
And I don't know if it was stress. I don't remember what it was, or she had another viral infection or whatever it was that fired up her immune system again. We're going to be talking about the immune system. And we both looked at each other and said, these people just have bad immune systems. They have bad immune systems. Same thing we talked about last week in Epstein-Barr. They have the people who are, and we haven't listed, did you briefly mention any of the symptoms? Because like every symptom known to man has been ascribed to Lyme disease.
Oh yeah, I haven't.
Okay, so we'll mention the main ones that we see. But in the end, what happens is so many people have Lyme. Here's your dilemma. So many people have Lyme in their system. Mom and dad don't have the symptoms. The kid has the symptoms. Right. Okay. Somehow, and mom and dad may have tested negative for Lyme, or they may have tested positive for Lyme, or the kid may have tested negative for Lyme, or may have tested positive for Lyme. And it's a very real scenario for the Lyme patient because, as Dr. Gates indicated, the testing is inconsistent. It's unreliable. One day you got it, one day you don't. We actually have a paradigm, or a logarithm that we use. We have a very specific, organized way that we go about a chronic problem. And when a Lyme patient comes in here, they're not a Lyme patient. They're an autoimmune patient.
Right.
And a stress case.
Right.
They're an autoimmune patient and stress. Stress kind of perpetuates everything, but they're an autoimmune patient. And we don't usually look at Epstein-Barr virus or cytomegalovirus or Coxsackie virus or any of these things until much later in our protocol, because by the time we usually get the first part of our protocols accomplished, a lot of times the symptoms that were being prescribed to those entities are gone. And what does that tell us? It tells us they were not a problem for this patient, that they were kind of a red herring. Would you say?
Exactly.
Would that be a good way to put it?
I completely agree.
So this is something that we, and it's hard for us because you're looking at, you want to help these people, but then you have all this data coming at you saying, well, you're an idiot. You don't know what you're talking about. It's Lyme. And and I don't know, you're going to talk about hygienics and
Mhm.
okay, and it's Lyme, and the test said this, and when this goes back to when we started, and kind of the entry point of even as clinicians, we had to let go of all that and say, this doesn't make sense. The only thing that makes sense is these people have bad immune systems and they're getting sick, and these people don't have bad immune systems and they're not getting sick.
Exactly.
Okay.
Exactly. 100%.
Exactly.
That says it.
I tease him too much.
We kid. So those who have Lyme disease present with things like fatigue, headaches, pains in their joints, pains in their muscles. Sometimes they have peripheral neuropathies, meaning they may develop Bell's palsy, where one side of their face droops up here. They can't close their eye. The lower face droops as well. They may have conditions that mimic a pinched nerve in the lower back, so they may get pain down their leg. They can have stiff neck, difficulty concentrating, confusion, trouble remembering names. These are all the symptoms, really, of Lyme disease.
And why is that in general?
It's probably due to the inflammation, in our opinion.
Hitting different organ systems
Mm-hmm.
or different structures in different people.
Exactly.
So you get this crazy plethora,
Mm-hmm.
you like that word,
I do.
of symptoms. You just get this constellation, all these like different symptoms. Like, so you can have 10 different Lyme patients come in here and they'll have 10 different sets of symptoms.
Yeah. And so the testing for Lyme, let's go now to the chronic Lyme issue. Most of these practitioners doing chronic Lyme, there's not a lot of them, but they are part of typically the International Lyme and Associated Disease Society, where they acknowledge that Lyme is a chronic issue, and they like to broach it with antibiotics.
I wish the president is here in Reno. I don't know if you knew that or not.
I did not.
He is.
Wow, I did not know
He's a
that.
dentist, an alternative dentist.
I did not even know that.
Yeah.
Okay.
I'll tell you who it is afterwards.
All right.
I'm not going to out him on here.
Yeah. And so just in our observation, a lot of these practitioners use intravenous antibiotics or oral administration of antibiotics for a long period of time. Sometimes a person will get a port, or
2-3 years,
ports where they just have the antibiotics or PICC lines, antibiotics delivered for these year-long periods of
like
time.
our journalist.
Yes, and I have seen cases where that has worked.
Yeah.
However, we have also seen a lot of cases, I would say in our observation, more cases where that hasn't worked. And that is the reason why Dr. Horowitz, who is a International Lyme and Associated Disease Society doctor, wrote this book. And the interesting part about his book was that he said, if the antibiotics don't work, then you have to start looking at all these other features that Dr. Rutherford and I address on a day-to-day basis, including autoimmune issues, gastrointestinal dysfunction, foods and nutrition, hormones, stress.
Yeah.
Have I said inflammation? You have mitochondrial dysfunction. You have to start addressing all these other disparate pieces in a person's physiology, and lots of times in doing that, heavy metals, for all you heavy metal lovers out there, you have to address those in order for the antibiotics to work. The interesting thing that Dr. Rutherford and I have seen is that so commonly the person had taken antibiotics, they didn't feel better, then they go through our program not on antibiotics, and all of a sudden they start feeling better. And it's because possibly we went and we cleaned up everything that was wrecked by that infectious disease process in the first 30 days.
The way we were introduced to this book, by the way, was pretty interesting because we have there's a patient that we have had off and on in this office for years. We have a chiropractic office. She'd come in years ago for chiropractic, and she was actually in medical field, in medical sales, and she's been in the alternative field. Although she's not a medical doctor, she's not a practitioner, but she's pretty bright when it comes to this stuff. She ultimately brought her significant other in here for Lyme disease. Didn't tell us why. I was kind of surprised because she kind of knows everything. If you're out there watching, you know who I'm talking about. And so I kind of, after her husband or her significant other was in here for like a week or two, she came and said, you have to read this book. Now, a lot of times people who have done a lot of studying, they want to come in here and their concept is these guys have the vehicle for me to get them to do what I want them to do, as opposed to what they do, which fixes people all the time. I'm going to get them to do what I want to do. And that's not a good client or patient or whatever you want to call it here. Okay. So I'm thinking this is what's going on. And so she gives me this book and I don't read it. She says, you got to read this book. You got to read this book. So I'm thinking this is one of those things where I'm going to read this book and she's going to go, see, this is why I have to do this with my husband because I researched this and so on and so forth. Well, she asked me about 12 times if I read the book. So finally I thought to read the book. And in essence, the first third of the book tells you about acute pain, acute Lyme. And there must be like 50 different drug regimens in here. And I'm reading it. And then at the end of the first third of the book, he basically says, and I'm paraphrasing, he basically says, and if you don't get to it in the first 30 days, you're basically screwed. And if you do get to it in the first 30 days and nothing works, in either of these two cases, this is what you need to do. So we read the rest of the book and it was basically our clinic, which answered the question as to why these people were getting better, right, based on what you just got done explaining, when we weren't really treating anybody for Lyme prior to reading this and prior to her coming in. We just basically, people came in, they had all these symptoms. One of the things that they were told they have happened to be Lyme. We would treat them. For the most part, they'd get better. And we were just all looking at each other going, well, I guess it's the immune system. But it's what Dr. Gates just said. It's all of those things. He basically says, you know, if you haven't done this, then you need to do that. And everything that you said, you just articulated before I went off on that, is what is the last 2/3 of this book, which is why, and he'd probably do a lot more efficiently than this. If you're going to watch this, Dr. Richard Horowitz, we love you to death, but and what I liked about Dr. Horowitz was he did find a lot of ways to cut costs patients, yes, dramatically, because a lot of those of you who are watching Lyme, you probably know that there's a lot of pretty chunky, financially chunky protocols out there, which can work, okay, you know, in certain percentages of the patient, but he's figured out a way. So those of you on the East Coast, where is he in Connecticut?
He's New York, somewhere in New York.
Okay,
yeah.
So anyway, but that kind of, I'm just trying to help them to understand why we think that we kind of have a grip on this.
Well, and one of the main things that Lyme does is it goes intracellular. And so that's why a lot of time you have a hard time culturing the Lyme bacteria, because it goes within your cells and it's not necessarily floating around in your bloodstream. And so with that, the Lyme bacteria can disrupt our mitochondria. Our mitochondria make energy for us. However, the Lyme bacteria, like other chronic viral infections like Epstein-Barr virus that we talked about last week, can use our mitochondria to make energy for it, or just the action of it being inside of our cells can break down our mitochondria, and that can create fatigue, which is one of the cardinal and most disabling symptoms of Lyme disease. Right. Also, if you've been on antibiotics for 3 years, probably have some imbalance in your gut microflora. And so he talks extensively about basically normalizing that gut microflora, but it goes beyond probiotics. You have to do things with diet in order to feed the good bacteria and starve the bad bacteria. We've talked extensively ad nauseum about some of those protocols. The adrenal glands, because a lot of you out there have been suffering and you may have mitochondrial dysfunction. So now the stress glands in your body are trying to take over to make more energy for you, and they can only do that for a certain length of time. Added on top of that, that you're not feeling well and you're still trying to work and you still have a family, stress goes to a 10 out of 10. And finally, the adrenal glands typically peter out and are not able to make enough of their stress hormones. And then heavy metals can be an issue. So a heavy metal burden can cause issues with the immune system to get overreactive or kill the wrong things and not kill the right things, like the Lyme bacteria. And so sometimes the metals have to come out of the individual.
Sometimes.
Not
as frequently as maybe
in our experience. Yes, in exactly. Our experience. And so those are the main things, as well as inflammation, and then sex hormones. It seems to be that a lot of Lyme patients get dysregulation of sex hormones. Guys get low testosterone. Females may get high testosterone. Right. Those are the classic features of it. But probably we're going to find out that Lyme is an autoimmune issue. Right. Those who suffer with the symptoms, or it's an immune dysregulation issue. Like we talked about last week with Epstein-Barr virus, how the immune system doesn't remember Epstein-Barr virus in those who have chronic fatigue due to Epstein-Barr virus. And so one side of the immune system gets overreactive, another side of the immune system isn't picking up on it, and then you have this chronic infection. Or there's some sort of antibody with Lyme disease that we're not able to quantify yet.
And we're pretty movable off of that point at this point in time, because we had no idea when we started what we were doing that we were going to develop an autoimmune practice. No matter what happens, no matter who comes in here, whether they come in here with a migraine, headache, or vertigo, or dizziness, or balance, if they come in here with gut problems, if they come here with restless leg syndrome, and it's chronic. And I try not to, like, as I'm doing a consult, I try not to think, okay, this person's got to be autoimmune because they're in our office, and it never fails. There becomes an autoimmune and or a stress component. And now we're talking about fight flight syndrome as opposed to you just being stressed because you got to pay your bills. You know, it's like we're talking like a fight flight syndrome or post-traumatic stress syndrome. And you put those two together and you are done. You have chronic problems. And it just depends on what's going to show up. It blows your immune system, and then you develop some sort of an autoimmunity. And you are going to hear this. I'm going to tell you, it's going to come out because that's what our protocol is, essentially. I mean, people come in here for one thing, the other. But we run them through this protocol that we've developed over a period of time, and they do well. So they wouldn't do well if it wasn't their immune system that was the main issue, and that's our argument. You know, I mean, it's not an argument for us, but that's our position on Lyme, that it's an immune problem. It's an immune problem. And tons of people out there got Lyme. A lot of people are having no problem with it. They got a good immune system. Maybe they're not stressed, and they're good. But once this thing hits and once it starts going, it's like domino effect. One system will go, and then another system will go, and then another system will go. You have to stop that. You have to stop that downward spiral. You have to reverse it. Your path to Lyme success starts in the gut.
Right.
And if you've watched 200 hours of us, and there's probably 200 hours of Lyme on us blabbing away, everything starts in the gut. But as Dr. Gates said, everybody wants to make a buck off of it today. So now we get on television, take lactobacillus, take probiotics. That'll do it. No, that won't do it. It's very complex. And if you want to know how complex it is, look up one of our talks on irritable bowel syndrome or digestive bowel or something like that, and you'll see how complex that is. Then while you're going to your internist and you're getting your colonoscopies and you're getting your endoscopies and nobody can see anything wrong with you and you're still bloating and you're still constipation. The gut is there's a little bit of a gauntlet to run there. Actually, there's a considerable gauntlet to run there, but the pieces are known. You just got to figure out which pieces are for that person. You start there. The immune system starts calming down. 75% of immune systems in the gut. From there, then things really start to clear up as to what else needs to be taken care of. That's how it's done. So don't make it sound like we know everything, but we know this.
Yeah, and we know what we see clinically, and we evaluate both sides of the data and try to figure out what is actually accurate, separating fact from fiction on this issue. And
so what else? You
really
didn't mention IGeneX.
Oh, okay, so
just because everybody comes in with their IGeneX.
IGeneX is the test, and we've used it where it's the Western blot test.
Okay.
And so
and I wanted to bring that out because people come in now, they have their IGeneX test. They don't have their Western blot test. So I just wanted people to know that.
And so with the Western blot test, you have to have antibodies to, I believe, 2 of the kilodalton basically strains of the DNA of the bacteria. Now there's a CDC criteria for it too, because again, the Western blot was originally devised for surveillance issues, not clinical diagnosis issues, according to the CDC and the Center for Infectious Disease specialties. But the Western blot is now being used to track who has been exposed to the Lyme bacteria. And most alternative Lyme practitioners use the IGeneX test to verify if somebody has Lyme or a co-infection. We haven't even gone into co-infections. So you briefly mentioned Babesia and Ehrlichia, and that's a whole area or talk unto itself.
Yeah, so the testing is it's inconsistent, it's unreliable. You have to compare it to a history. Just because a person doesn't have it, if they got every symptom of it, you have to consider it. If a person doesn't have any symptoms of it and they have it, you have to consider that maybe that's not what's caused, maybe that's not an issue with them and they don't have to go through $30,000 of chelation or whatever it is. And so that kind of covers the 2 different areas that we see all the time. So that kind of covers it, I think.
I think so.
If there's anything, if you are a Lyme sufferer or you've been told you're a Lyme sufferer and you're watching this and there's something that we haven't covered, feel free to let us know. Feel free to send us an email. If you got any questions, feel free to send the question. Dr. Gates is our man on the move when it comes to answering these questions or researching them. Because if you ask a question that we don't know, we want to know what's there. Dr. Gates is our research and development department, and so I know he would give it his best shot at trying to get you an answer if at all possible. But I think we have covered pretty well right now, and we could probably answer most of your questions. So next week it'll be
anxiety and panic attacks for Becky.
Yes. And Becky, that's a great topic. And these are my favorite topics. We're now finally starting to get into those topics of like Epstein-Barr virus that drives me nuts. Because people come in, I got Epstein-Barr virus. I'm like, yeah, okay. But it's like, I got Epstein-Barr virus. I got Lyme. And I'm not making fun of you guys. I'm just saying this is a big problem for you. And an anxiety we see it all the time. And there's a couple of things. And if you have anxiety to the point where you went to a hospital and you had heart palpitations and you were told everything was normal, you want to watch this next week, okay? Because that happens to be maybe my favorite symptom relative to anxiety and stress. And we'll talk about that next week. So, okay. So thank you for watching. I hope this was helpful. And I'm finding out that a lot of people are watching this. So we're going to try to be a little more interesting. I guess it's working, but we have a lot of people watching us. Thank you for watching us. It really makes us feel like this is worthwhile now. And let us know if there's topics that you want, and we will see you next week.
Mm-hmm. And thank you for watching. Send those questions to powerhealthtalk.com.
There you go.
I will do my best to get back to you.
All righty.